Good evening, everybody, and welcome to the BMJ IHI session on for the International Forum. The session is on leadership and culture for change during COVID-19. My name is Pierre. I am IHI's, the Institute for Healthcare Improvement's Chief Global Programs and Partnership Officer, and I am a clinical professor of maternal child health at University of North Carolina School of Public Health. It's a great pleasure to be with all of you, and I hope that we can provide for you a session that is very relevant to the current COVID epidemic that we find ourselves in, and provide you with some useful information around the very important topic of leadership and culture at this time. I hope you will agree that we have an exciting program for you. I will spend a little while at the top of the program talking about rapid improvement during the time of COVID. We will also be hearing from Dr. Vipul Aggarwal via video. Dr. Aggarwal will not be able to be with us today, so we'll have a presentation on video from Dr. Aggarwal without the opportunity of asking him questions. But we will have live with us Dr. Atul Mohan Kochhar, as well as Professor Randeep Gularia. And so we look forward to both their presentations as well as some questions from you, which I'm sure they would be delighted to answer. So just a couple of housekeeping issues. Please note that you will not be able to turn your speakers on or your video. This is unfortunately, with such a large group, we're not able to do that. We do ask you, however, to contribute and participate, and we would love to see any content questions that you might have in the Q&A box. You'll notice at the bottom of your screen, there's a little Q&A button. If you click on that, you'll have a little box that opens up and you can ask questions, and we'll try to answer them after the talks. If there are any technical issues, please do activate the chat box. We have Kyle Rolf, as well as other members of the BMJ technical support team who are on standby and who will provide you with any support that you may need if you encounter any problems during the presentation. We will start, as I say, with my presentation. But before we get there, what I wanted to do was to just give you a little, since these are the case studies that will be presented after my presentation. I wanted to start off with a story which I think is familiar to many of you. This is Dr. Li Wenliang. So Dr. Li Wenliang was, sadly, an ophthalmologist in Wuhan, China. His contribution to what we're talking about today was the story of him being very astute while he was undertaking his work. He noticed that there was a cluster of cases that reminded him of the flu-like illnesses that had happened during the previous SARS virus epidemic. He had taken care of patients with pneumonia. He saw a sudden influx of patients he was admitting to his wards, and he then sent a WhatsApp message to his fellow clinicians, urging them to don protective clothing, PPE, and saying there's something going on that I want to make you aware of. Please be careful as you come into the hospital and take care of your patients. As many of you know, this was not well received by authorities. 3 days later, the police visited him and told him to stop what he was doing, stop spreading rumors. Sadly, Dr. Li Wenliang himself contracted COVID, and a week later he died. And I'm illustrating this case firstly to honor Dr. Wenliang, because I think this was a very courageous act of his, which undoubtedly saved the lives of many of his fellow clinicians. It also alerted, I think, the public health system to the fact that something important was going on. But I think it's also a reminder, and it's very pertinent to this webinar that we are delivering today, for a couple of reasons. The first is the knowledge that we need to be able to respond rapidly to something particularly that we've not seen before, or for which we don't really have a lot of experience, comes from the front line. And we need a process to be able to understand that information, and as Dr. Li Wenliang did, rapidly disseminate it to the people who really need to know it. Now, WhatsApp groups have become very familiar to many of you, but the question that I think we'll be asking is there a formal process of surfacing this type of knowledge, rapidly disseminating it, and doing it in an environment and in a culture that allows knowledge which may not be welcome, but is critical for the care of our patients, to allow this knowledge to be surfaced, to be transparent, and for us as leaders and managers to act on it. So that's the challenge, really, about working in an environment where we are, particularly at the moment, we're dealing with something we've not seen before. But what can we learn from the front line? What can we learn very rapidly so we don't have to, in a year's time, look back and say, well, we should have done this. But in fact, we had the knowledge that was emerging at the time. Can we build systems that will allow us to deal with the situation? So what are the challenges that the system leaders are facing right now? Well, firstly, they are overwhelmed. They're overwhelmed with a ton of information. This information is coming at them from all directions. It's new, and it's usually coming from the top. It's to implement something that is not simple. It is a complex, multidimensional problem that they're dealing with. Secondly, it has to be adapted. There are protocols that are coming in from other parts of the world. They may well work in certain settings. We don't know if they're going to work in our settings. We need a way of being able to rapidly test them, adapt them to our context, and institutionalize work and toss aside those that are not working. We need a focus on information about the how. We're getting a lot of protocols. We're getting a lot of very sort of strictly clinical, tactical information, but we're not getting tactical information about the how. We need to be able to learn that, assemble it, and then spread that. COVID planning tends to be very centralized, particularly when the system is dealing with a very acute emergency. We tend to do the opposite of innovation. We tend to say, well, this is what needs to be done in a hurry. Here's what to do. Get on it and do it. And so the front line is not incorporated into that decision-making process. And finally, lots of things are happening simultaneously in different places. And so we need a way of integrating that information and coordinating it. So these are the challenges. And our challenge to you and to our speakers is, what can we do to integrate that and make a better learning system to deal with the challenge? So at this point, we wanted to just get a pulse from you about what's happening in your environment. So we're taking a quick poll. And Kyle, if I could ask you to activate the poll, and we would be very interested in you participating. It's a very simple set of questions. 3 questions. Firstly, as leaders, response to the pandemic, do you think that leadership, number 1, has it consolidated decision making? In other words, moved to more of a command and control response to the health system? Has it not really made any changes? Do you think it's business as usual, or do you think it's leadership as usual, I should say? Or are they really utilizing the information that is coming from the front line in a way that can be directed? So this is just a pulse check about what's happening in your neighborhood. So please do let us know what you think, and tell us what your discipline is as we hear from you. So, Kyle, can you just let me know when you've stopped the poll?
The poll is now on the screen here.
Okay, so the poll is concluded, is that correct? Okay, so I'm assuming that that's the final poll result. So a very interesting result, and not in fact one which I would have predicted, but I think it's good news. I'm taking it as really great news that from your experience, about 57%, nearly 60% of the institutions that you're aware of, that the leaders are responding to the COVID pandemic by utilizing rapid learning from the front line for decision making. So that is really great. And in fact, I think that I hope that what will come out of this COVID epidemic, and certainly it's the experience that I have personally seen in a number of the systems that I have worked in through the COVID epidemic, that in fact this has been an unleashing of rapid learning and decision making at the front line. But about a third of you, 37%, said that in fact the leadership and management has gone in the opposite direction. It's gone more towards command and control. And while command and control, and to be honest, it's potentially not a fair question, because you could be doing both command and control and rapid learning at the front line. But what we don't want to see is the precious learning from the front line not being incorporated as rapid decisions are being made. And just for you all to know, as you can see on the screen, the discipline represented on this call is fairly diverse, with mostly being represented by doctors at about 50%. So with that knowledge, I think we can move to the next part of this, which is my presentation on the role of leadership in specifically protecting health workers in the time of COVID. And I'm using this as an example. We could speak about pretty much any other aspect of the COVID response, but I wanted to focus on this very important issue of health worker protection, since health workers have been so badly affected in the workplace, and we need them so badly to help us with the COVID response. So just to start with another poll, this was in fact conducted by the Gallup organization in the US, and I thought that this was a somewhat depressing statistic, that only 36% of healthcare workers in the United States that they would be safe if they followed their organization's health policies. So that every organization has issued policies, is providing PPEs, hopefully, but there's a high degree of anxiety amongst healthcare workers that they are not safe. And we, as leaders, have to be able to do something about that, because without the confidence of our health workers, and actually without the physical protection of our healthcare workers, we have no chance of mounting an effective response for COVID. So the starting point really of an effective response is to try to understand the system and to organize the system. And in fact, of all the contributions that improvement science, I think, has made to the COVID epidemic, it's this essential element of sense making. So for those of you who are working in this improvement space, you know that we start with being very clear about the aim and very focused on the problem at hand. And in this case, it's the healthy and functional workforce, making them healthy, keeping them healthy, and keeping them functional. And we thought, as we were working, and a lot of this work relates to the work that I'm doing right now in South Africa with the provincial governments around trying to keep the health workforce intact. And we've thought of three metrics that should be reasonably easy to follow, which is health worker to health worker infections, keeping an eye on staff absences, and some metric of emotional health. We'll talk a little bit about that. We think that there are 3 key action streams that we need to keep our eye on. Helping leaders to be effective, the specific work around the prevention and the management of infections of health workers, and then a specific piece of work around keeping an eye and helping out with both the emotional and physical health of health workers. And for each one of these action streams, there are a set of actions. And we are, and this is where I think the exciting opportunity for rapid learning comes, because there are many leaders that we are encountering who really are making big progress around how to be effective leaders through visible and decisive management, effective communications, working well with labor relations. That's a particular issue here in South Africa. In terms of prevention and management, these are things that will be pretty evident and obvious to you: staff infections, patient-staff infections, and the management once a health worker gets exposed, and making sure that they have the knowledge and preparation to be able to prevent themselves from getting infected, understanding that most of these infections are coming in from the community, and they're not getting infected by patients, they're getting infected in the community, bringing these infections into the hospitals and clinics and infecting their co-workers. And then attention to the emotional and physical health, managing staff anxiety and the basic care needs of the work environment. And so for all of these, we are now assembling the knowledge of not so much the what to do, because there's, as I say, a ton of information on clinical protocols, infection prevention protocols, but how do we implement them in the facilities around the country? So we believe that there are 2 tasks that leaders need to think about. The first is, how can we create this environment? And we speak about the culture for learning, the culture for rapid change, and the leadership has an absolutely vital role to play in creating that culture and enabling environment. And secondly, how do we use a systematic learning approach to enable that change? So it's not just creating the culture. There's a lot of places that I've seen that work on leadership culture, but they don't then have a systematic method to surface those ideas, test them, and track them to make sure that change is really happening. There's a very good article which I can recommend to you, which came out in June in JAMA, by Shannon Felt, and they did a survey that and they assembled the sources of anxiety for health workers. Practical: give us access to PPE. We're frightened of getting exposed to COVID and taking that infection home. We're frightened of spreading infection spreading in the workplace. We worry that we won't be taken care of. Our supports are not being taken care of. Do I really know what to do, how to take care of COVID patients? And do I have access to the information? What's going on in my place? Who's being infected? Are my leaders and managers being transparent with me? And they crystallized, and I thought this was a very, very helpful a set of questions as if asked by the health workers. Will you hear me? Will you protect me? Will you prepare me? Will you support me? And will you care for me? I think very, very powerful to turn it on its head and say, these are the questions for health workers. And the work that we're doing in South Africa now is turning this, in fact, into a survey, which is being now administered across to find out from the care workers, how do they feel about their own protection? Do they felt heard, protected, prepared, supported, and cared for? As well as being able to give them the opportunities for asking, for providing very specific information for leaders to the question, what really matters to you? Can you tell us one thing that we could be doing that would improve your sense of being protected, cared for, looked after by your leadership? And honestly, every time this question is asked, there is no shortage of very practical, good information. So this is a survey that was conducted in one of the larger hospitals in the Cape Town area. And and we organized the responses according to the action streams that I mentioned about our driver diagram. And you can see immediately leaders and managers have a real direct line to the worries and concerns of their health workers and very actionable items that they can start working on. And one of the most important messages that came out of the survey was a health workers saying, don't ask us these questions if you're not going to do something about us. So help us by actually testing and acting on these suggestions that we are making. So that is their plea. And that's the opportunity, because we know we can use a systematic improvement method to respond to these very good suggestions that are being made by the frontline health staff. So as leaders and managers that we're working with are coming together, we are starting to put together for them and for rapid scale up across the system a series of bundles, ideas that are grouped according to these action areas. So for visible and decisive management, if you want to be a visible and decisive manager, which we believe is crucial for creating that environment and for sparking change for the better, we are saying you need to do these 4 things. Now, it may not be just these 4 things, but if you do these 4 things, walk your daily walkabout, going to the front line every day and asking what matters to you, acting quickly on the things that are easily fixable, and getting more involved in the QI process for those things that are a little harder. We say if you do those 4 things every day, you will likely be a visible and decisive manager. Likewise, and I won't go through all of them, but for each of these action areas, we have this emerging bundle of activities that we're saying to leaders, please do these things. You will be much more likely to succeed in protecting health workers in this case, or any of the other tasks that you are interested in if you follow this. So we're saying, and this is not something I invented, this is what W. Edwards Deming said, if you encounter a problem, you have 2 options. Either fix it, because it's something that you should be doing anyway, or you as a leader have the opportunity to quickly get on top of and be decisive with, or change it. Now, changing it implies that you need to make some change to the system. And so we'll talk about those 2 options that you have as leader. And first of all, in the fix it category, these are simple actions that you can do today. It's what you as a leader and a manager should do, and be careful about mandating the front line to quickly fix it, because that is what many leaders say, well, there's the problem, fix it. But in fact, what needs to happen actually is system change. But what you as leaders can certainly do is remove barriers and bring in resources. So there's a whole category of things that could just be done. Now, a lot of what needs to be fixed can be what we call pebbles in the shoe, little things that annoyances or really factors that can be influenced and fixed by asking the staff what it is that they are. If in fact you need to change something, then you need to think about the improvement method. And for those of you who use the PDSA method, you will recognize I'm talking PDSA here, Plan, Do, Study, Act, in simple terms. Firstly, understand the concern, you measure the current state and you map the system. Secondly, you surface the best ideas from your staff and you get ideas from your peers. Thirdly, you actually do it, you try it out. Don't implement it at scale, try it out on a small scale. And then very importantly, measure, did it work? And then finally, if it does, scale it up, establish new standard operating procedures, communicate the plan, and by all means measure to make sure that in fact you're not slipping back. So to recap, we're suggesting that there are 2 tasks for leadership. One is to create this culture, this enabling environment for learning and rapid change to occur. And secondly, use a systematic approach for rapid improvement. Either use the fix-it approach or turn to a method for systematic learning. So my parting comment will really come from Derek Feely, who some of you may know is our president and CEO who just retired from IHI, he said when he was interviewed about what would be your message to other leaders and managers at the time of COVID, he said 3 things. Be transparent. This is not a time for sugarcoating, for making things seem better than they are or worse than they are. Just be frank, out and about, communicate with people. Do not sit back and wait to be asked. Second, be the voice of calm. People need, in this anxiety-ridden time, they need calmness and certainty. And certainly, you need to convey the sense of order. Certainly, than what I was trying to explain, that our biggest contribution is making sense of a difficult situation. And very importantly, be together. Get out there to the front line. Don't sit back in your office and ask the questions. What matters to you? What support do you need? And it's a time for humility, which is to say we don't know all the answers. This is new, but we will learn, and we will learn from you at the front line. So I am now going to, before we move on to, sorry, I think I may have hit the wrong button there. Let me go back to this last slide and see whether there are any questions in the Q&A. And so I see we do have a few questions. And because we don't have much time, I'm not sure if I'm going to be able to get to all of them. I like the question from Mahib Singh, which says, what measures are to be taken to reduce anxiety amongst the health workers? We've done a lot of work with leaders and managers in the hospitals and facilities in the area in which I am right now, which is the Western Cape province in South Africa, and some real wisdom about this question of communication with the health workers. One of the most salient comments I've heard is that facts alone are not enough. In other words, people say, well, you know, we will tell people exactly what it is to alleviate their anxiety. In fact, the facts alone are essential, but not enough. And so the communication to the health worker is primarily along those 7 questions that I showed you about what it is that the health workers are most concerned about. First and foremost, health workers are concerned that they're going to catch COVID, or that they're going to catch COVID and take it back to their families. So there has to be some very explicit leadership activity around taking that concern very seriously, providing the PPEs, providing the information about how to protect yourself, showing that you really care, showing that you are really taking, trying things out and asking them for their best ideas about how to prevent them from getting infected from each other. So I would, Mahip, it's a complex response, but I think if you followed the proposal that I gave about, measure, find out from your staff how they are, what their ideas are, prioritize your ideas to how to help them, and enact, either fix it or change it. And I think if you take them along with you on that journey, I think that you're in good shape to reduce their anxiety. So there are some, please enlighten on the importance of trust in leadership in difficult times. And I think trust is earned, and it's difficult to be one kind of a leader one day and then say, trust me, the next day. I think that if you look at the leadership, being an effective and decisive leader, that bundle of activities that we had suggested, get out to the front line, ask people constantly what matters to them, act decisively if there are simple things that you as a leader can fix, use a consistent method, use transparent data. These are, if you are visibly seen to be doing these things, you will gain the trust of your staff. And I think that's why we're trying to package it, because people say, well, I'm going to try this, I'm going to try that. We say, no, just try these 4 things and do them every day. And you will gain the trust of your of your staff. I think that I am unfortunately going to run out. I have run out of time. I'm just looking at the time. There are lots of really great questions here. These slides will, of course, be available to you. And I would also, there's been a huge amount being written, and we have tried to collect as much of this as possible on the IHI site. So if you go to ihi.org and you go to the COVID resources area, you will find, I hope, a lot of questions, answers to some of these really great questions that have come through. So I am actually, at this point, if you will forgive me for not answering all of your questions, I'm going to move on to the video presentation. Otherwise, we're not going to give Dr. Kochhar and Professor Gularia enough time. And so the presentation now will come from Vipul, Dr. Vipul Aggarwal. Dr. Aggarwal will be talking about the Ayushman Bharat scheme and what COVID-19 means for vulnerable populations. And Kyle, I will click on the button, or you will, and by magic, we will hear from Dr. Aggarwal.
A very good evening to all. First of all, I would like to thank the organizers for giving me an opportunity to be with you and share my thoughts. My name is Dr. Vipul Aggarwal. I'm an IPS officer, and currently I'm serving as Deputy CEO at National Health Authority, which is the implementing agency for the Ayushman Bharat project of Government of India. Next, please. So the subject for discussion is then the leadership and culture for change with specific reference to the COVID pandemic. So before coming to the topic, I would like to, in a very brief, I would like to explain as to what we are doing. Next, please. So Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, ABPMJ, it is a flagship scheme of the Ministry of Health and Family Welfare, Government of India, which was launched in September 2018. And incidentally, it is the biggest health care insurance in public sector throughout the world. So if we see in a snapshot, so far of the 54 crore odd beneficiaries, we have issued 12.5 crore e-cards so far, with hospital admissions of 1.08 crores and approximately 14,000 crores worth of spending so far on the project. We have a base of around 22,800 odd hospitals, which includes a 45% private participation. And the remarkable feature is the portability, wherein our beneficiaries are entitled to care anywhere across the country, not limited to their state or region of their registration. So far, we have handled approximately 250 crore worth of portability cases. Plus, we have a robust call center facility wherein call center operatives round the clock are attending to calls both inbound and outbound, with 63 lakh calls being made so far. And we have approximately 18 lakh plus mobile app downloads through ABPMJ application. So if we see the curve on the right side, as we see that there has been a steady growth in terms of pre-authorizations and admissions in the project so far, except for the COVID. If you can see the drop in the last 3 months, it has been an outcome or the result of COVID pandemic. And again, the figures have started going up as the relaxations have started coming in the lockdown. Next, please. ABPMJ over a period of time has gone past its traditional role, and we are now looking at state level convergences, including 25 state UTs, and now we are looking at private sector participation, because when we were conceived as a new organization, we were aimed to reach to the goal of universal health care. And for that, we are expanding our base and improving the capacities of both the states as well as other organizations, including the private sector participation, wherein we are receiving proposals to extend the facilities to organizations like Uber, All India Truck Welfare Association. Plus, we are also into continuous learning, and our monitoring evaluation division has published approximately 20 odd papers and policy briefs, which not only help us in improving our work functioning, at the same time it gives an insight into various policy matters and improving the efficiencies in the longer run. We have also provided platform to other organizations. We are in consultation with Central Armed Police Forces, Ministry of Road Transport Highways, ESIC, and other organizations to take care of their health insurance schemes. The remarkable feature of NHA is the robust IT platform, which is acknowledged across the country, and it is one of the best acknowledged platforms globally. So coming to the COVID pandemic, the COVID pandemic has resulted in a lot of challenges for us. If you see the statistics, we've had so far 1.8 million cases with more than 0.5 million active cases and 1.2 odd million cases who have recovered. There's a 2% approximate death rate, and now the doubling time is approximately 21 days. So confirmed cases of the samples tested are approximately 9%. As against that, the health system of the country has approximately less than 1 bed per 1,000 population. The doctor population ratio is also not on a very positive, encouraging side. It is 1:1,445, as we can see, and 40,000 ventilators to a population of 1.3 billion. That is still low if we see the way the pandemic is increasing. But at the same time, we have improved a lot in terms of our capacities over the last 2 months, and our health system is so far it has delivered in tune with the requirements of the times. Next, please. So not only an impact on the COVID patients as such, it has created an impact or challenge to all the other diseases also, including the serious diseases. So if you can see that the communicable diseases, the admissions have dropped by more than 50%, including most of the diseases, there has been a drop in admissions. Similarly, for non-communicable diseases, where we see that cancer and heart patients and patients with serious illnesses have been deprived because of many of the health facilities getting closed, or the patients having a fear of infection. So all these are leading to a situation wherein we are not being able to cater to the population which have other illnesses. Similarly, the mother and child care services have also taken a hit with increase in death rates of children by approximately 10%, maternal death approximately 9% in middle and low income countries. So if we see in India, there has been a decrease in institutional deliveries and home deliveries both, whereas home deliveries by skilled attendants had reduced by more than 15%. That's a significant number. So similarly for TB, there has been a 25% dip in the TB detection over the last 3 months. So this has a potential of amplifying deaths by approximately 13%. That again is a side effect or aftermath of this COVID pandemic that we are faced with. Next. Coming to the NHA's response and the leadership and cultural issues that we have faced, and here I would like to highlight the NHA leadership's response, which has come to the test of time. We have drafted the working model for NHA creating executive committees so that the decision making is delegated. We are making the teams accountable for work with cultivated strategic partnerships, leading to a new set of leaders emerging and taking the responsibility. The existing resources and talents are being reshaped to create new lines of leaders. There's an environment of continuous learning and adaptability on the go, and the rethought of the top leadership's role and more on vision and guide to sail through rather than taking all the decisions to themselves. So this has been a great leadership decision making, and the results that we are seeing in the last 2 to 3 months, especially during the COVID times. And we have also come out with the reimagining of hierarchical structure, wherein a hybrid model of hierarchy has been evolved with small, focused and cross-functional teams with definite deliverables and timelines coming to the fore. This we would like to make this a success in other organizations also. So if we see the culture paradigm, so NHA has focused on technology as well as organizational culture. So we have focused on technologies to work remotely along with capacity building exercises, both within the NHA and the state health authority agencies, Work from home in a government setup is becoming a norm, and we have encouraged that to the extent that it does not hamper the functioning. At the same time, lots of issues relating to infection and mobility related issues are taken care. We have taken initiatives to enhance communication, and we have gone for regular team retrospectives to reflect what can be improved, how the culture should be changed so that it becomes conducive to changes. We have encouraged the online sessions, creating an environment for well-being, at the same time creating a sense of motivation also among the employees. We have, as I said, created decentralized cross-divisional executive teams to take care of the new initiatives. So not only it has resulted in cohesion, it has increased the confidence level in the next line of leadership, and has helped us to evolve new leaders in the teams. So continuing with the COVID response, we have had different facets of our response. Coming first to the core activity of testing and treatment. So we have come out with testing and treatment packages to take care of the COVID challenge in more than 22,000 odd hospitals which I am empaneled with us. We have designed COVID packages which enable the hospitals and the healthcare providers associated with us to take care of the patients. And we are also providing inputs from the costing packages, because all the states are adopting packages as per their prevailing circumstances. Plus, to expand the hospital base, especially to take care of the situation wherein many of the hospitals had stopped operations during COVID times, we have empaneled more than 1,500 hospitals, and we have provided information, and at the same time we have come out with a ABPMJ light version in our IT systems, so that the empanelment becomes easier. So we have done away with the more formal system of empanelment to take care of the requirements of these COVID times. At the same time, to improve the capacities of the state health agencies in fighting COVID, we have guided them constantly over this pandemic period. We have deployed resources to enable the COVID helpline call center. We in fact are managing the 1075 call center of the Government of India also, apart from our 14555 ABPMJ call center. We are providing hand-holding to all the 26 states and union territories in implementation of testing and treatment strategies. And we are supporting designing the models which can be adopted to acquire private hospitals and dedicate to COVID-19 mitigation. To sum up, we can conclude that the people, the leaders having a flexible mindset are in a better situation to take care of unprecedented situations like COVID. If we do not adapt to the changed circumstances, we fail as our role as leaders. So we also need to groom leaders at all levels in the organization. So not only the top leadership, but we need leadership at both operational and the ground level, so that all such challenges can be handled in a much better manner, in a more cohesive manner. And there should be a culture of mutual trust within the organization. Ultimately, we have to achieve our objectives, and only a teamwork, a dedicated and a cohesive team can achieve those objectives. So with this, I would like to end my presentation. Thank you very much.
Thank you very much, and great thanks to Dr. Aggarwal. And I'm sorry he won't be able to answer. I see good questions in the chat box, which I don't feel like I should presume to be able to answer. But I think what we could maybe do is send some across to Dr. Aggarwal and see if he would be prepared to answer them. So I think we should move on, I will. Here we go. So we have up next Dr. Atul Mohan Kochhar. Dr. Kochhar is the Chief Executive Officer at the National Accreditation Board for Hospitals and Healthcare Providers. As a constituent board of Quality Council of India, the NABH is the principal accreditation for hospitals in India. So Dr. Atul Mohan Kochhar, welcome to us, to this session, and we look forward to hearing from you now.
Thank you so much, Pierre. This has been a wonderful discussion so far. Your talk and Dr. Vipul's talk actually practically covered all aspects of leadership and culture change during the COVID. So this was fantastic. The way you took us through the concerns of the staff, the cultural changes required, the fix-it approach or change-it approach, and then followed by all the good changes which the Ayushman Bharat Yojana has brought about under the leadership of Dr. Vipul and team. I'm here to here for the next 5 minutes, next 6 minutes, odd minutes. So please excuse me if I exceed that. I've just collected together a collage of photographs, which I'll quickly rush through to tell you the NABH experience about what exactly NABH is. NABH is part of the Quality Council of India initiative. But first of all, let me thank you for this opportunity to be in this esteemed gathering and present my thoughts. Quality Council of India was established in '97. It's responsible for creating the ecosystem of quality culture in India with all aspects. Mr. Adil Zainul Bhai is the chairman and Dr. R.P. Singh is the secretary. They are appointed by the Honorable Prime Minister's office. And this is the rough structure of the National Accreditation Board. There are 5 boards to talk about. We have a certification body board. Our sister board is NABL, which played a key role in empowering the labs to test this RT-PCR assays. We have a National Accreditation Board for Education and Training, and ours is the board which looks after the accreditation of hospitals and healthcare organizations. We have a promotion board, then we have a whole lot of special projects like PPID. It's a total of which look after various aspects. We have international benchmarking and recognition by all affiliated boards. ISQA and ASQA are the main boards which concern healthcare organizations. We work very closely with all national bodies, all corporations, and into all spheres from food safety to Swachh Bharat to cleanliness. We work very actively with National Health Authority. These are the healthcare marks. We work very closely with Bureau of Indian Standards. So practically, Quality Council of India today is working hand in hand for all quality initiatives. This is a brief snap of all the programs which are undertaken by our National Accreditation Board for hospitals and healthcare providers, NABH. There are 3 broad categories of accreditation, certification, and empanelment, and total about 19 programs running with total of 9,600 plus organizations which are partnering with us under various programs. Our hospital program is a flagship program where we accredit all the bigger hospitals. Our entry level is a very ambitious program to take quality to all the nooks and corners of our vast country. We take it to very small setups like PHC, SHC, blood banks, emergency. And we also do CGHS and ECHS, which are kind of government empanelments, which test the basic compliance to certain statutory norms and quality practices. So this is about that. Like I told, ISQA, ASQA, our standards and our organization both are accredited and certified by ISQA. We also are open to compliances, assessments. We ourselves are open to scrutiny and periodic audits, and our standards are into their 5th edition. So our standards are freely downloadable, most of the cases, and soon we'll be making others also free. And this is a nominally priced guidebook which takes through the entire course. And on the right, you can see our certificate for the latest 5th edition, which we launched in February, before COVID happened. So COVID, when it happened, changed everything. And with this change, we learned to adapt to a new normal. We learned to salute, and we found and learned to salute and recognize new warriors, our nursing officer, our OT technicians, our doctors, which were already working hard. So suddenly this was a huge disruption for all of us, like you mentioned, and we learned to salute. And today also, from the heart, bottom of our hearts, we salute all our Corona warriors, the frontline or otherwise. We also learned that, in the words of the great Charles Darwin, that it's not the strongest of the species that survives, not the most intelligent, but the one most responsive to change. So the only option with us is to adapt and overcome. So many quotes abound. The internet, if you change nothing, of course, nothing will change. And if you continue to do the same thing, it's not logical to expect a different result. So I was privy to your talk, which was given, and such a wonderful talk. So you've already taken us through the concerns of the staff, the idea of a change, and how a good support system, how a good leadership should change. So there are three broad processes about technology, processes, and our people. So technology was already there. We already had licenses to virtual meetings, which was seldom used, I must admit. We are a standards organization, so our processes and our systems were in place. Some which were not, we tried to immediately fix them. For the first 2 weeks, we were caught napping or caught looking here and there, deciding what to do, how to deal with this thing. So we took out our dusty old policies, whatever they were, and tried to revamp them, improve them, and we tried to use the technology. But the more core strength which NABH derived was we are a very lean organization. Our total NABH strength of staff, of regular staff, is about 35, and we are ably assisted by about 20 of young professionals which work very hard with us. Total of about 50 staff and about 9,600 organization. That's a lot of work, cyclical work about surveillance, about on-ground assessments, desktop assessments in all various categories. We are supported by a huge team of very able assessors, which come from very diverse backgrounds, but are experts in their fields. So our people are our core strength, and these are the people which motivated us to change. And this is the biggest driving force which we learned from, that the future depends on what we do in the present. So this is what we took upon us to improve the present in whatever challenges, whatever thing, and we decided, and we kind of adapted ourselves to work from home. Now, work from home was a very new thing for us. I mean, this was a notional thing which was there in our HR manuals, but again, those all went for a toss. And again, there were sudden new changes. With all our female staff, which are the core of NABH, all our staff, I mean, for males or females, this was a real challenges which came up, handling children, handling husbands and spouses, and without help. I mean, the help was very difficult to get by during these lockdowns, and it was a total lockdown initial. Now we are into various stages. So many new challenges came up during the work from home, and so many memes abound. And there were certain plus points about what not to wear. I mean, same shirts and unwashed. But jokes apart, this was a very new experience, and I must very proudly say that all of our entire team NABH worked, if not 24/7, at least 18 into 7 to accredit, to certify, to coordinate with our committee members, and take things forward in a very, very positive manner. There were concerns about health. There were anxieties, like you said, about what could happen, and there were so many things. And there were actually mental challenges, actually. Mental health issues were there. There were lots of stress. Some people were not, they were caught unaware and caught away from home, and that was itself a challenge. So emotional health became very focused. So we had to take care of all these things and then move forward, because hospitals were looking up to us. Hospitals, because they needed to adapt very fast. And just like Dr. Vipul also said, NHA maps their benefits to NABH accredited hospitals. So there's a fiscal benefit also. So all those hospitals which were pending assessment, if they could not enroll, or if they could not be assessed, or if they could not be reviewed by a committee, they were facing huge losses, which would have compounded their loss, which itself is great. I mean, most of the hospitals, healthcare organization during these uncertain times, their incomes have gone down, their economical deficits have grown. So this NABH assessment meant a lot to them, and I'm very proud, and I must place it on record that all our committees. So this was the new normal. All committees held. We held nearly 500 committee meetings. So this was a big challenge. I mean, from one to another, internationally, across borders, for consultations, for training, whatever. I mean, so these committees, all our accreditation, our certification committees, they literally burned the midnight oil. So all boundaries of time and space were relatively gray zoned. They were overlapping, and practically across hours we were working. So there was no 9 to 5 concept. The dates, we could not remember the dates. So practically across hours, across days, these things started happening. And good result came out. So during the past 2.5 months, we enrolled more than 1,400 new hospitals, a small scale one, and about 96 bigger hospitals into our fold. By reviewing their corrective and preventive action, by giving out advisories, and this was practically all on virtual mode, practically all. Going forward, we also tried to connect with our people. We released and launched new initiative called Quality Connect, Learning with NABH. We reached out to people with webinar till they were frozen with Zoom fatigue. And that's a legal Scrabble word, I must say. There were so many, from emotional health to Ayush to all spectrums. We reached out with practical trainings, and we were very well received. So people who had time, who did not have time, they all logged in thousands actually, and benefited from these free training sessions. And we propose and plan to continue all these initiatives which have been given birth during this uncertain time, and people can log in. We are placing everything on our website. They can log in and they can keep coming back and seeing again and again all these wonderful wisdom from the experts. We also initiated our digital health standard. So digital health was a good tool. Which was a gift kind of an opportunity which was given to us by the government. It was made legal. Telemedicine consult was made legal in March. Digital health standards are very broad category, very massive spectrum of M-Health, about interoperability, security, privacy, all aspects of data capturing, consent. So these are good standards which are in now advanced stage of being drafted, and they'll be placed for public opinion soon. So this was another opportunity. As we speak, there are now 4 assessments going on today. We've already completed. So this was one new area we tried to intervene: virtual assessments. So virtual assessments as of today are a well controlled healthcare partners who were due for assessments. We have devised a standardized protocol where we, through these platforms, through the use of mobile linkages, through the use of other desktop surveillance and a virtual face-to-face connect virtually, we try to assess the hospital. So this, we have already completed about 65 assessments. And as we speak, there are 4 assessments going on today. So practically, this has been a good change, which is helping our partners and again, our staff, our moderators, our assessors. Each and one of them is working very hard to bring things to a fruition. So this was the new genesis. The future, of course, is uncertain. Uncertainty because we do not know. This is a new virus. We don't know how it will behave, what prospects of travel, because we are a travel-based assessment, protocol-based agency. But now with the virtual, we realize that uncertainty will remain for a few months. And the situation is a little gray in certain areas, not one shade, not 50 shades, but a million shades of gray. So we realize also that the takeaways from this pandemic is that we cannot control, rather that's a myth. So all we have is now, but we do not control. And the only thing which we have is a positive attitude. Any leader, I mean, we can say that this sort of attitude is not going to work. We have to be participative. We have to have a skin in the game. We have to participate, and we have to show, which Pierre, you also said in your talk, that showing is, just actions, not verb. So we don't have to talk, we have to act, and we have to be a part of the team. So that's the only thing. What helps is if the organization already has a strong foundation. So here I'm very fortunate that NABH is built on a strong foundation of integrity, honesty, our service attitude. We are trying to improve on the efficiency because turnaround times are always a challenge, but we are reliable and we know that we are the face of the industry. So we work for them, and if we do not improve, then so many people suffer. This is just a WhatsApp forward which I just collated here. This is a very important concept. Be like a tree. You have to stay grounded. This holds true for any organization across board. We have to stay grounded. We have to connect with our roots, which are our partners, our people. We have to turn over a new leaf, of course. That means devise new standardized protocols. We have to be flexible and ready to bend. We have to enjoy unique natural beauty, which means we have to ultimately connect with nature, ultimately. So that's a broader metaphor, that we have to be in sync with reality and keep growing. And that's the only way whereby we can reach out to the poorest of the poor. So all our policy, unless they reach out to the smallest, unless we reach out to the smallest of the healthcare organization and try to bring in a culture change, creating islands of quality is not going to help. So if there's one learning from this pandemic, one major learning it has come out is that quality has been a huge enabler of managing this sudden disruption. So all our partner organizations have fared well, and I'm sure there lots of studies will come out later out. We are still collating the data that all our partner organization, because they were already vested in quality, already invested with SOPs, so they were used to mock drills. They adapted very quickly to the changing scenario. They could adapt to the changing guidelines. Practically, they were changing guidelines every day. So that's the only way. And that concept can only come if we reach out to the smallest of the organizations and bring out quality changes for them. And so this is the last line in the last man in the line. We have to target them, and the quality has to reach them. So another WhatsApp thing, but very, very relevant, that one day everything will fall into place just the way it should be. So meanwhile, we should focus on improvement and betterment and create a good life for yourself. So there's a very famous Hindi quote by great man on this same thing, and I'll end with that picture abhi baki hai mere dost. So that's the way life should be. And NABH stands and is committed to quality, safety, and wellness. Thank you so much. Thank you. I think you'll have to unmute yourself. Yeah.
I did. Thank you so much. Yeah, Dr. Kochhar, very wonderful talk. And we do have time, a little bit of time, for a couple of good questions that have come through. I want to go to the question from Jawed Iqbal, who says, you mentioned the sweet spot of change. Who developed this model, and is there any research tagged behind it?
Sorry?
Did you hear the question, Dr. Kochhar?
That was for you or for me?
I think it's for you, but maybe it was for me. I think it was for you.
No. See, whoever decides it, these are the learnings, we take them. So best time is to take learning from anywhere, actually. So the idea is not to discuss models. The idea is not to talk about the dots and the crosses of the T, but to take things in spirit and take it forward, actually. So with due credit given to whoever the philosopher was, I'm sure I can share that, the reference, but to move solidly as a team, wherever you are, whoever you are, whatever part of organization you are.
Yeah. So we have a question from Srinivasan, who says, this is what I would say is a provocation, which is in quality during emergency, anything less than failure is accepted. So Srinivasan is saying that that in fact much lower levels of quality are being accepted during this because it is an emergency. I first of all, I would ask if you would agree with that, and secondly, is this the case? You know, is this something that you've encountered or accommodating in your approach at the NABH?
Well, I think that's a wonderful question. Firstly, wonderful question, but at the same time, I would not agree. Why would I not agree? Is because see. I mean, this has been a sudden disruption. Our entire knowledge of this virus is only today's, 6th August is 7 months, and assuming it started on 1st of January or December, it's practically 8 months. So every day new discoveries are being made, and every person in whatever capacity, whether related to this virus or not, I mean, whether related to development of a vaccine or a medical doctor or in nursing, of it, they are having new challenges and sharing their experiences. So this has been an example of the entire global world, civilized world, coming together and sharing their experiences. And when we say that certain journals, even the reputed ones like Lancet or JAMA, or the best of one, the Science, the Nature, with very high impact factors. So they have been sharing a protocol of rapid publication methodologies. So that does not mean that it has not been peer reviewed. That only means that they all are willing to collaborate to come forward. So that was the first part, because each one is coming forward. So future knowledge is going to be maybe different. That does not mean that fraud has been committed or standards have been lowered. That means that at point of that today's point, that information is relevant and should be shared. Like, for example, I'm a dermatologist. Now, talking like a dermatology, today there are 280 dermatological signs and symptoms of COVID which have been described and collated in the form of a great atlas, which is now available for free download on so many platforms. Like even American Academy of Dermatology, the JAD journal, has placed it on its site. And going forward, some of these signs and symptoms may prove to be because of follow the Koch's laws or something, some may not. But that does not mean that the standards have been lowered. Similarly, when talking about NABH, when we are going for virtual assessments, we are giving our best to be as thorough as possible without exposing our assessors to the harms or the dangers of exposure. There may be certain areas. There may be certain areas where we may not be as thorough as possible, but we try our best. And this thoroughness can sometimes be analogous to what happens on ground assessments also. So one basic point is that perfect is the enemy of the good. So one, we could suspend everything and wait for things to normalize and be perfect one day, and then resume operations. The other is to carry on with the new normal with integrity, with honesty, with as much capacity as possible. And then if something may not prove right, because hindsight vision will be 20/20, then maybe at least in our conscience we should not suffer that we did not give our best that time. So I think each one of us standing up, each one of us giving a fighting chance, and each one of us is giving a best effort to fighting this pandemic. So we must applaud that. Yeah.
Thank you very much.
Right.
No, wonderful. Thank you so much. Unfortunately, we have a lot of brilliant questions, which we just simply don't have time for, but I do want to give Professor Gularia his chance. Randeep Gularia is a pulmonologist, as I am, so it's nice to know the two of us here. and is the director of the All India Institute of Medical Sciences, and is credited with the establishment of India's first Center for Pulmonary Medicines and Sleep Disorders. He was honored by the Government of India with the Padma Shri, which is the 4th highest Indian civilian award. It's our pleasure to have you, Professor, with us, and look forward to your presentation.
Thank you very much, Pierre, and I'd like to thank the organizers for inviting me. I shall just be talking to you about the experience that we've had at the All India Institute of Medical Sciences, and many of the points that have been already covered. I shall just try and reiterate upon them as we go along. When we're talking of leadership, I think it's important that we understand that what really matters as far as leadership is a vision, a culture, and the ability to operationalize things when it comes to leadership management. And those are essential as far as leadership is concerned. Medical leadership is something which is a big challenge because it's a physician's ability to serve as both a manager and a leader or diverse teams in pursuit of maximally effective patient care. And that seems to be the mantra that we have to really see how we can be very, very effective as far as patient care is concerned. And it's been usually divided into type 1 leaders, which are doctors working in formal leadership roles, which are akin to institutional and service leaders, or type 2, that is in doctors working in informal leadership role, like doctors working as leaders in the clinical practice, who subsequently have this leadership role. So moving on from this leadership background to COVID-19, I won't really stress upon this, but we all know that this started as an outbreak in China way back in December 2019, and we have a pandemic now which is affecting the whole world. In India, the first case actually came on the 30th of January 2020, and this was from an individual who flew in from outside India, but this was the beginning of the pandemic as far as India is concerned. In the All India Institute of Medical Sciences has been involved at a national level also. Many of us, including myself, are part of the National Task Force, which the Government of India created as far as management of COVID is concerned. We're also involved in forming national guidelines for the Ministry of Health and Family Welfare. The Prime Minister's Office formed empowered groups. I was one member of one of the groups which are looking at strategies for the country, and the group that I was in was looking at how we improve the infrastructure and healthcare facilities both at a district level and even at secondary and tertiary levels. And I also chaired the clinical research group of the Indian Council for Medical Sciences, which is trying to look at research protocols as far as COVID-19 is concerned. But coming to the All India Institute of Medical Sciences, the key challenges that we had when we started way back in February was how do we protect our healthcare workers? How do we keep them motivated? And the immediate increase that we felt there would be for intensive care beds, for facilities which are properly built in terms of infection control. And then how do we train our physicians who have no idea of COVID-19? How do we develop protocols which are really changing every day in terms of our knowledge and awareness? And then how do we mentor and do capacity building for other institutions across the country? Because this is one of the mandate that this All India Institute of Medical Sciences, which is a premier tertiary institute, has in terms of academic activities. And then also generation of awareness on COVID appropriate behavior among staff and public. So what we did was, and this is something I did way back in February, was we formed a COVID-19 task force. This was basically from people from hospital administration, clinicians in pulmonary medicine, in critical care, in infectious diseases, microbiologists, and they were formed the core group that would look at how we could manage COVID-19 as far as our hospital was concerned. We also formed subcommittees, a resource management committee, because we really felt that if the pandemic blew out of proportion, there would be a need to have more and more resources. A human resource committee, because we would need a higher number of human resources, and we would have to get residents and faculty from departments which were not really looking at infectious diseases or critical care to come into the pool in terms of managing these patients. The medical management related committee, which would come out with the guidelines and keep updating them and keep talking to the doctors. The IEC committee, and committee for training and infection control measures. And this is something which I think is very, very important, because when we start looking at this committee for infection control, it was something that we had to do for everyone. How do you don and doff a PPE? How do you really protect yourself? And this is not only for the faculty or the residents or the nursing officers, even for the technicians or the sanitary workers or anyone who goes into a COVID area. So we had the Hospital Infection Control Committee actually hold workshops for 3 hours every day, morning, evening, for the last few months. And they did this very, very sincerely so that every individual in the hospital had some training as far as infection control is concerned. As a matter of fact, I realized a few, I would say weeks later, that a lot of infection was coming from the community. Our security guards who were working outside, who were outsourced, were coming and getting infected, and we were developing clusters in non-COVID areas. And therefore, we decided that even those who are not working in non-COVID areas, but are coming to the hospital, will have to have infection control training. And we started training them through online media, through these workshops as far as infection control is concerned. We also developed a diagnostic management committee because we need to have a good supply chain as far as the VTM, the viral transport media, the nasal swabs, and various other kits are concerned as far as diagnosis is concerned, because you need to have these tests quickly. I started a daily meeting program. We meet every day in the morning. This is a group of faculty, nursing officers, technicians, residents. All of them come together. We have a brief meeting. Sometimes it lasts for about half an hour, but sometimes it can even last for 2 hours. We discuss everything that these people on the front line go through, and we try and see how we can solve them. It could be a simple issue of feeling that the PPEs are not of good quality. So a committee was formed to look at the personal protection equipment with residents, nursing officers as part of the committee. And they then started really seeing that, is this PPE good enough? Are the N95 masks good enough? We had this whole issue of the nursing officers saying that the duty hours of 8 hours is something they cannot do because of it's impossible to do those duty hours wearing a full PPE. So we changed the roster and we had a 6 hours roster so that the nursing officers and the residents would spend 6 hours wearing PPEs in the COVID areas. So you need to talk to everyone, and you need to, as was mentioned, visit the site, reassure your healthcare workers, because that is something which becomes very, very important. I remember the first few days, there was such a lot of panic. One of the nursing officers was so panicky that she refused to go home. She felt that she had got infected and she would give this infection to everyone in her family. And this was a COVID suspect patient. It was not even a COVID confirmed patient. It took me 2 or 3 hours to sit there and reassure her that we would do everything as far as this was concerned, and she fell into the low risk category. I remember a resident who was in anesthesia and was in critical care, and she told me, I don't mind working in the COVID ward, but I'm the only daughter of my parents. So if something happens to me, you must ensure that my parents are looked after. These are the stories that we need to really look at and ensure our healthcare workers that we are there behind them to really look after them. And then there's the issue of reorganization and prioritization of hospital services. At the same time, making sure that emergency non-COVID work does not suffer. Oncology services don't suffer. You can't have patients who have a resectable lesion not being operated upon and going on to an unresectable lesion. Daycare has to continue. Your blood transfusion for thalassemia patients has to continue. And all the other activities have to continue. So how do you balance that out as far as the hospital is concerned? So our response was basically infrastructure, human resource planning, process redesigning, testing, information, education, and communication, the IEC, research on COVID, and we are an academic institute. So how do we continue with our academic program, the exams, the entrance, the exit exam, and the entire institute decided to donate 1 day's salary to the Prime Minister's Care Fund, which was for COVID care for the COVID-19 pandemic. So I'll just briefly touch upon them. As far as infrastructure was concerned, something I realized when we saw what was happening in Europe, especially in Spain and Italy, that we will need to really upscale our infrastructure, and we have to keep the COVID area separate from a non-COVID area. So we have a National Cancer Institute, which is about 45 to 50 kilometers from here. It's a 700 bedded facility, but it's just started. We had just started it with about 100 beds. We quickly converted that in 2 areas in that. One was the guest house, the Vishram Sadan, which were 2 towers for patients, attendants to stay. They were individual rooms which were with an attached toilet. We converted that into a COVID care center way back in March. And this was then done because at the ground, where the entrance was, where we converted that into a screening area. The first floor was converted into the place where the healthcare workers stayed, donning and doffing could be done. A dedicated lift was there, and the entire tower became a management area for stable COVID patients. The National Cancer Institute, we converted into a hospital with wards and ICU. It has a capacity of 700 beds, but we're using only 100. We procured a lot of equipment and we operationalized it totally so that we could have almost 700 patients or more admitted in that area. And this was actually something vital because there was a time when we were close to having 1,000 patients in our hospital who were COVID positive. And it was a panic situation for me because I was wondering, where else will I get these beds if more and more patients come? Luckily, we plateaued off and we are now at a downward trend. And now the number of patients has actually come down to close to 400 to 500 in our hospital, but we were close to 1,000 and this was a panic situation. We also converted a trauma center, which is again a 250 bedded hospital around less than a kilometer away from our main hospital, into a COVID hospital. Because of the lockdown, the number of trauma patients had become less. We moved trauma into our main hospital and converted this into an entire COVID hospital. Again, restructuring everything, both from the air conditioning to the entrance and the exit. And then in the main hospital, we developed a triage area for emergency, a screening area, and many patients who come with severe acute respiratory illness, you don't know whether they're COVID positive or negative. So a COVID suspect ward was created where these patients were managed with a presumptive diagnosis of COVID positive. And if they were positive, they were shifted to the trauma center or to the National Cancer Institute. If they were negative, then they went to the respective wards. We also realized very early that we will need machinery and equipment. So very early, we started buying more and more ventilators. We started repeating our orders. We were buying actually more ventilators from the Dragger company. We repeated that order and got 40 more ventilators. We got the high flow nasal cannulas. It's a story in itself. The protective equipment was something that we really focused on, the personal protection equipment. We made sure that there was a buffered supply as far as supply chain was concerned. And one of the other things that we realized early was that we're going to have need for extensive dialysis. So very early, I managed to get 5 extra dialysis machines. And this is something which I think we did very quickly, because after that, there was a huge shortage and the supply was not as easy as in the initial part. As far as resource planning is concerned, we designated a nodal officer for each of these areas. There was a roster made by the task force and there was rotation of faculty, residents and staff so that there would be no burnout. During the lockdown, transportation for our staff became a huge problem, and we arranged for the buses from the Delhi Transport Corporation, and we hired these buses to make sure that our staff was comfortable. At that point in time, we were giving N95, we were not giving N95 masks to all hospital employees. It was only for the patients, the workers, healthcare workers in the COVID area. But we started having outbreaks because of the extra pulmonary manifestation of COVID, even in other wards. We had stroke patients in neurology, myocardial infarction in cardiology. And I realized that this is something which will create a panic as far as healthcare workers were concerned. And we decided to give N95 masks to all healthcare workers to give them a sense of confidence. And this was even beyond what the current guidelines recommend. All the employees were exempted from the biometric attendance so that they felt that there was really no fear of transmission. And we started giving medical benefits to facilities to all employees who were even on contract or outsource and were working in the hospital, although they were not entitled to this. We arranged for temporary accommodation for doctors and staff posted in COVID in specialized areas like guest houses and hotels, because sometimes the COVID healthcare workers were reluctant to go home and wanted to spend some time away from their residence because they had elderly staying at home and they were fearful that they would transmit the infection. Testing was something that we focused on because we realized that if we don't have a rapid turnaround time for testing, we will not be able to really triage our patients properly. We started with the RT-PCR. We had what was the CCRF, the common research facility, where we have a research facility with the BCL2 and 3 laboratory. What we did was we quickly converted into a virology section, and we put more staff there so that we could have multiple runs of the RT-PCR test, and the report could be given within a few hours rather than taking a few days. We started the CBNAT also, which was basically for tuberculosis, but the cartridge-based test, which gives a report in 2 hours. And this could be done for patients who came and needed emergency surgery, where you needed an early report. We also validated the rapid antigen test, which has now become quite popular in our country. And this also helped us as far as getting an early diagnosis, because this gives you a result in less than 15 minutes. Protocol guidelines were made, the clinical management COVID-19 protocols were made, advanced life support algorithm was made. We had an airway management criteria, and management of people with diabetes in COVID facilities was something we realized was not available. So these guidelines and protocols were also made. We started focusing a lot on teleconsultations, because we realized that non-COVID patients were suffering, and all departments started aggressive teleconsultation to all the non-COVID patients. Infection control, of course, was something that we did very aggressively. Dignified management of dead bodies guidelines were also made. And there was also management of biomedical waste generation, which was also done by our team in terms of how to go about doing this. As I said, we did training of staff for COVID care, which was through webinar, online training modules and videos. We used an e-platform, a Saral platform, which we use for all our academic activities, and the OnTop platform. We trained 13,262 employees, which was medical, paramedical officers, and other support staff for infection control practices, like I mentioned. And we also trained almost 2,212 doctors, interns, nursing officers through a special online platform, which was also used at this point in time. As far as
Prof, hello. Sorry, so sorry to interrupt you. We've just about run out of time, but if you wouldn't mind wrapping.
Yeah.
Thank you.
So we did a lot of national training program, which was basically for the government of India. We did training as far as the SAARC countries was concerned, which was also for the region. And we also had a lot of research activities. We constituted a research committee way back in March, and a number of research projects was also done as far as this is concerned. We've continued our academic activities, online classes. We also had the entrance and exit exams, and we have a lot of information portals. I'll quickly run through them: the information booklets, the AIIMS website. We have done a large number of videos for the ministry also, and also webinars, which are now available on YouTube also. We also have a helpline, which is useful. And therefore, in conclusion, what I'd like to say is that during a crisis, healthcare leadership has to be innovative, inclusive, and prepared for any exigency. These challenges become more relevant in an academic institution due to varying priorities. And still, I feel there are significant leadership gaps which exist in our country, because we really have no formal training, and you need to learn as you go. So I'll conclude here. Thank you very much.
Thank you so much, Professor Gularia. And I think it's pretty evident from your talk, the extraordinary role that AIIMS has played, both in leadership and also in the provision of significant amount of technical information. And I would encourage our viewers to go to the AIIMS site, as you're suggesting, to have a look at the great number of resources that are available, as you have described. So sadly, our hour and a half has rapidly come to an end, and I'm sorry to have rushed you a little bit, Prof, at the end, but we do need to respect the time of our viewers. I am very grateful to all of you who have attended. I just wanted to make a couple of announcements before you all go. We do hope very much, COVID allowing, that we will be seeing you face to face at the international forum, first international forum for the BMJI in, I won't say which city because we're not 100% sure, but in 2021. It is all in development right now. You can visit the site as shown on your screen for more information. We would, many of you have submitted fantastic abstracts for this year's conference that sadly had to be postponed. We would love you to similarly submit and participate in next year's meeting with updated information. And so very much look forward to seeing you all there. So with that, a good evening to you all, and thank you for your participation, and we will see you hopefully next week. There is a follow-up session, BMJIHI, which you will be receiving in your email, and hope to see you there as well. Thank you so much to our speakers. Wonderful to hear all this information, and see you hopefully all soon.